This session is dedicated to understanding where renal denervation fits in today, how it's performed, and what real-world practice looks like. I'm delighted to be joined by leading experts from the United States. Dr. Randolph from Moses H. Cone Memorial Hospital in Greensboro, North Carolina, Dr. Bott from Virginia Heart in Arlington, Virginia, Dr. Kurtene from Columbia University Medical Center and New York Presbyterian Hospital in New York, and Dr. Tarani from Innova Heart and Vascular Institute in Falls Church, Virginia. It's a really great panel and group of speakers, and I think you're going to learn a lot today. But before we begin, a reminder to collect your CME points for today's sessions. Make sure you click on the CME button to request your certificate. And also remember, if you've got any questions, to ask them in the Q&A box. I'll be monitoring that as the program goes along. All right, well now Dr. Randolph will set the stage with a background and guidelines update, helping us understand where renal denervation fits in today's treatment landscape. Dr. Randolph, the stage is yours.
Thank you very much, Dr. Bott. I appreciate the introduction. So as you mentioned, my goal today is to talk about the general background of hypertension, our challenges in managing it, and think about how renal denervation falls into managing these patients. My disclosures are listed as you can see. All right. So I'm sure this audience is well aware that hypertension is a very challenging problem that affects many people. Up to almost half of the adult population in the United States has hypertension. What may be more surprising, though, is that less than 1 in 4 of our patients actually has their hypertension controlled to a goal of less than 130/80, which we're aiming for almost all patients. This is unfortunate because cardiovascular disease, as we know, is the leading cause of death worldwide, and hypertension is the greatest contributor to cardiovascular death and mortality. So as you can see here, people whose blood pressures are uncontrolled at even 140/90, ultimately hypertension contributes to over 3.5 million deaths worldwide attributable to ischemic heart disease. If you look at a combination of ischemic and hemorrhagic stroke, over 2.5 million deaths worldwide occur, and this is related directly to their uncontrolled hypertension. Similar things are seen with chronic kidney disease. Over 500,000 people each year die primarily because their hypertension led to these other conditions. Well, why is this? Well, what we know is that hypertension affects everywhere in the body that there's a blood vessel. And it starts to wreak havoc on our bodies before it's even perceptible or before you can even feel the difference. And this is why we call it the silent killer. We know that it leads to changes at the nephron level that can ultimately cause us to develop proteinuria before we see detectable changes in creatinine. It can cause LVH before we actually get heart failure or atrial fibrillation and so forth. It can also start to cause vascular changes in the brain that ultimately lead to dementia, stroke, TIAs, and so forth. The good news, though, is that even small changes in blood pressure control can actually lead to demonstrable risk reduction from cardiovascular death. And so what we know is that even just a 5 millimeter of mercury improvement in blood pressure can make a significant difference. Reducing your blood pressure by 5 millimeters of mercury lowers your chance of overall cardiovascular death or major cardiovascular event, by 10%. It lowers your risk of stroke or heart failure by 13%. And if you can even get your blood pressure down even lower by 10 points, that nearly reduces your relative risk of cardiovascular disease even more. As you can see, stroke, our relative risk reduction goes down by 27%, 28% for heart failure, and so forth. And the good thing to know is that this is incremental. So for every 10 millimeters of mercury that you lower someone's blood pressure, you're reducing their relative risk by another 27, 28%, et cetera. So the challenge is that despite knowing that we have effective medications, hypertension remains one of the greatest opportunities to improve cardiovascular outcomes, and we're not getting really any better with this over time. And so what you can see here is that if we look back to the mid-2000s, about 50%, 54% of people who were all people with hypertension were controlled to less than 140/80. Those who had also treatment with medications, about 72% of those people were controlled. Fast forward to more recent times, 2021 through 23, if anything, our numbers are worse compared to then, which is really, really disheartening. It just highlights the importance and the challenges in successfully achieving sustained blood pressure control in real world patients. Well, why is it that we're having such a challenging time controlling these patients? Well, there's a lot of factors. Some of them are patient factors, some of them are ourselves as providers and physicians, some of them are disease-related factors themselves. So we know that our patients struggle with pill burden, right? Every time we give a patient another pill, they're less and less likely to take it. And some of our patients are taking 10, 20, or more medications. And often these medications can cause side effects. It also contributes to increased costs, which is, of course, a concern for most of our patients. We also know that despite the fact that lifestyle modification with diet and exercise works, it's sometimes challenging to be consistently adherent with it over time. I already highlighted the fact that sometimes patients don't actually feel their hypertension, and so they might be more motivated to actually address other medical conditions that they do feel. And some people just don't want to take medications for whatever beliefs underlying cultural beliefs that they may have. But it's certainly not all on the patients. We also contribute. We think about the therapeutic inertia that sometimes physicians, other providers may exhibit, where a patient comes into the clinic, their blood pressure is 138, and we say, well, it's good enough. But if you remember what I showed 2 slides ago, it's not good enough, right? Every 5 to 10 millimeters of mercury that we improve someone's blood pressure translates into real relative risk reduction. We sometimes don't reach often enough for combination therapies, which have been shown time and time again to be effective and to help patients lower their pill burden and more adherent to their medications. Sometimes we're not as good of a communicators as we think we might be in helping our patients to truly understand the importance of managing their hypertension. And then, of course, we think about the disease-related factors, such as truly resistant hypertension, other conditions that contribute, such as obesity, chronic kidney disease, and sympathetic overactivity all contribute to challenges with actually achieving sustained blood pressure control. So we know diet and exercise, medications are the mainstay of treating hypertension. But where does renal denervation fit into this, and what is it? Well, renal denervation is a catheter-based procedure that we know disrupts the afferent and efferent innervation of the renal sympathetic nerves. We know that all of the efferent signals from the sympathetic nervous system to the kidneys serve to promote elevated blood pressure. And so interrupting that pathway serves to help create a sustained reduction in blood pressure over time. This is a procedure that is an always-on therapy, meaning that it does not require daily adherence to a pill or ingesting anything to continue to have impact on blood pressure. As of 2023, there are 2 FDA-approved catheters, devices for this procedure, and they are the Paradise ultrasound system and the Simplicity spiral system. So what do we know about RDN? We know that it has been consistently shown across multiple sham-controlled trials that it contributes to significant reductions in ambulatory and office blood pressure, and that it works in patients who are both on and off medications. We also now know that sustained reductions are seen in long-term follow-up and even increasingly impressive results with time. So at this point, after years of investigation, the field is now moving beyond proof of concept. Our current discussions are focusing less on does it work and efficacy, and thinking more about the actual implementation of which patients should be selected for this procedure. This should say the recent 2025 ACC AHA hypertension guidelines did provide some first level of insight in this guideline body on how a renal denervation should be implemented into practice. And so what we know is that they gave a level of a recommendation of 2B with a level of evidence BR for patients for whom their blood pressure is greater than 140 systolic and greater than 90 diastolic, and who have EGFRs greater than equal to 40. This is a patient population who can be considered. And they recommended thinking about it for patients who have resistant hypertension, despite being optimally treated with medication and lifestyle, as well as for those who have intolerable side effects to medications. Of course, they mentioned several times that this is to be used as an adjunct, not instead of adherence to lifestyle modifications and medications. They also provided recommendations, level 1 recommendation, that patients who are being considered for renal denervation should be doing so as a part of a multidisciplinary team. And that team should have expertise in treating and diagnosing resistant hypertension as well as RDN. And finally, they emphasized again with level of 1 recommendation that this should be done as a shared decision-making process between the team and the patient. So what are the steps that patients should go through before being referred for renal denervation? First and foremost, it's so important to make sure that we actually confirm that they truly have hypertension. It is really important to make sure that we assess patients' blood pressures out of office, make sure that we are not missing white coat hypertension. It's also important that we understand that our patients are taking their blood pressures properly, that everything is being accurately assessed, that they have the right cuffs, and that they know how to check their blood pressures. We need to make sure that they understand how to maximize their lifestyle. They understand the importance of the 150 minutes of exercise weekly, how strength training, how limiting our sodium intake and following a DASH diet can contribute to significant blood pressure reductions, and that they have adequate time to make those efforts. We also need to make sure that we are utilizing guideline-directed medical therapy. We cannot say that someone has resistant hypertension if they're on 25 of metoprolol, 10 of lisinopril. That's not what that means. And thinking about using combination medications as mentioned before. We need to evaluate for secondary causes. The 2025 guidelines also really highlighted the importance of ruling out hyperaldosteronism in patients, even if they do not have hypokalemia. Things that we already know, like looking for sleep apnea, as well as making sure that we've eliminated medications and alcohol, things like that, that can be contributing to people's hypertension. And of course, assessing their adherence, making sure that patients are actually ingesting regularly the medications that are prescribed. And if they are not, addressing any types of barriers that they may have to actually getting those medications. So in my practice, I find that the patients fall into 2 camps overall. There are the patients who truly have resistant hypertension, meaning they're uncontrolled on 3 or more medications, despite actually adhering to their therapy. And then there are also patients who are unable to tolerate their medications. Many patients come in with 20 medication intolerances, or they may be struggling through the medications, but really suffering from the side effects. And then there are others who just simply do not want to take medications for various reasons. Both of these patient populations have been studied and can be effectively managed with further optimized with the additional of RDN when appropriate. So for our clinic, we certainly follow the multidisciplinary team approach. As you're building an RDN clinic, you'll find that any one RDN clinic might look different from the next. The 2 things that are imperative for sure, you have to have a champion. And you also, and for me, that's our, of course, me, the preventive cardiologist, but you also need a proceduralist. It doesn't have to be a cardiologist. It doesn't have to be, that can vary from clinic to clinic for whatever works best for your patient population. We have integrated a clinical pharmacist as well as 2 nurse practitioners who are invaluable in the evaluation of these patients, both pre and post. We have 2 nurses who help us with patient care as well as tracking patients through the approval process. It's also very important in building this program that you have administrative support and buy-in, as well as expertise on the billing and coding of these procedures. So finally, key takeaways here. We know that uncontrolled hypertension remains a major problem, both in the United States and worldwide. We know that RDN is now approved by the FDA and endorsed in the ACC/AHA 2025 hypertension guidelines as an adjunct to be used in addition to lifestyle modification and medications. And we know that having a multidisciplinary team to help manage these patients both pre and post RDN is key. Thank you very much.
Well, that was really an amazing presentation. We have time maybe for a couple of quick questions here, just to try to stay on time. There are already great questions here. This one you just did address. Maybe the question was a little bit before you, but it says practically, where does this place renal denervation therapies in the hypertension pathway? Did you want to just give a quick recap of your thoughts there?
Sure. So this is certainly not something that we're doing for patients the first time they come into clinic. The first things that we want to do are make sure that they're actually checking their medications, their blood pressures properly, that they truly have hypertension. At that point, we're looking to optimize whatever medications they might be on, making sure that we're using guideline-directed medical therapies, the most potent medicines possible, combination therapies where possible, and then giving them some time too to work on their lifestyle. But for patients whose blood pressures remain uncontrolled despite doing those things, or despite not being able to tolerate medications, this is where we start thinking about RDN, especially once also for our resistant hypertensive patients, looking for secondary risk factors, right? Making sure they do not have renal artery stenosis, or that they don't have sleep apnea that's untreated, hyperaldosteronism, things like that I mentioned, alcohol, heavy alcohol use. All of these things are modifiable risk factors that can be addressed without stepping forward to RDN yet.
And along those lines, there's a question here, a very specific one from a Dr. Natarajan. Do you hold ACE, ARB, ARNI before checking for hyperaldosteronism?
So the new guidelines actually say we do not need to hold that. The only thing that needs to be held is your MRA. And so we, technically speaking, if somebody is on spironolactone, if anything, or eplerenone, if anything, their aldosterone levels are going to be higher. So you're not going to have a false negative. If anything, you might have a false positive, at which time you would definitely need to hold the medicine and have a washout period. So there's really a lot of encouragement for just going ahead and checking it as a screening level, because it's such an under-recognized condition that really does contribute to uncontrolled hypertension, and can potentially be addressed without continuing to just give patients more and more medications and not treating the underlying issue.
Yeah, it's a good point. A lot of folks aren't aware of the changes in the guidelines with respect to testing for hyperaldosteronism. Here's a question. Maybe I'll just throw it out to the panel for anyone who might want to comment. I'm just paraphrasing what the questioner says. I was recently asked about a renal denervation patient who was not, or potential patient who was not classically resistant, but unlikely to achieve durable control with medication alone. Panel opinions. So any quick thoughts about that from anyone?
I mean, I can jump in. I would basically say that one key thing is that it's important for you to see the patient yourself and to assess exactly what is being meant by this situation, because many patients that have difficult to control blood pressure have never been tried on combination therapy. They haven't been adequately tested in a way that's standard of care if you were in a hypertension clinic. Hypertension clinics are very hard to have. I mean, most patients with hypertension are treated by the primary care doctors, and pretty well for many of them, but there is a degree of sophistication that you need to be able to develop if you want to be in this space. And there's no substitute for seeing the patient yourself, talking to them directly about it, and then coming up with a diagnostic and then therapeutic plan.
Yeah, I think that's really great advice. Sometimes when the patients are referred in for these procedures, there's sort of been a workup, but maybe not a thorough one. And that's sort of what Dr. Randolph was alluding to as well, the importance of the multidisciplinary teams as the guidelines also endorse. Okay, well, to keep us on time, we ought to probably move on to the next presentation, which will be Dr. Bach, who's going to take us through a recorded demonstration of radiofrequency renal artery denervation. So, Dr. Bach, it's over to your presentation.
Great. It's great to be here with everybody. Thank you for inviting me. I just need to make sure that I have slide control here before I continue. I may ask that my slides be advanced as I go on. Anyway, today I'm going to be, here's some brief disclosures. Today I'm going to be talking about a radiofrequency denervation case. And just to give everybody a brief summary of how this is performed, radiofrequency renal denervation is one of the two currently available FDA-approved platforms for this procedure. This is done through, right now it's done through a 6 French axis through the femoral artery, although a radial catheter is in development. We selectively engage the renal arteries with a guide catheter, as we would with most interventions. And the spiral catheter itself has a helical design. It has gold electrodes that are placed about 5 millimeters apart on the catheter. And when you remove the guide wire after placing the catheter in your desired segment, it takes on its helical form so that those electrodes make contact with the intima. The radiofrequency is turned on. That radiofrequency energy is then converted to heat, and that melts the fat surrounding the nerves and essentially disperses the axons. Now, because these renal sympathetic nerves are unmyelinated, they do not regenerate. And so we think that this is a durable procedure. This is a nice schematic that I like to use both in presentations, and I actually show the patients this in the office. And please advance my slide. So the case I have for you is one of those cases that I'll remember for the rest of my life. She's a 48-year-old woman who has horrible blood pressure and has a lot of anxiety associated with that blood pressure. She carries her blood pressure cuff everywhere. And I remember the first time I saw her in the office, she told me that the reason she carried her cuff everywhere is because there are situations where she felt her blood pressure rising, and it would, she would go into this cycle about being increasingly worried about it, and she would need to go somewhere to relax. In one specific example, she was in a movie theater and she felt her blood pressure going up, and she put her cuff on, and the person behind her yelled at her because the cuff was making noise. And she said that, that was terribly embarrassing. And I just, I really felt for her. So this woman actually came to see us from Tennessee in the first 6 months after device approval. Her only medical problem was really resistant hypertension. As you can see, she meets criteria for resistant hypertension. She's on, high doses of 3 medications, and further titration of her medical regimen was really limited by either intolerable or dangerous side effects from thiazide diuretics, loop diuretics, and calcium antagonists. When she first came to see us from Tennessee, her office blood pressure was 162/96, and which was, pretty much typical of the detailed home blood pressure log that she provided us. We perform, as Dr. Randolph described, we perform a secondary hypertension workup on all patients. And in patients that do not, everybody does things a little bit differently. In patients that do not have a history of significant vascular disease or FMD in other locations, we typically screen them with a renal artery duplex. If they have a history of significant peripheral arterial disease or FMD, I'll generally order a CT scan. We also routinely screen them for hyperaldosteronism, which is much more common than I appreciated before we started our program. And we also screen for medications that might be contributing to blood pressure, such as ibuprofen, steroids, and medications like Alka-Seltzer. Next slide, please. So here are representative angiograms from her procedure. As you can see here, the first image, this is her left kidney, and you see an accessory vessel on the left. You never want to forget about potentially denervating the accessory vessels as long as they're between 3 and 8 millimeters, which is the ideal size to accommodate the helical catheter and get good electrode contact. And so you can see on the leftmost panel here that the entire lower pole of the left kidney is missing, and that will generally clue you in that there's an accessory somewhere. This can also be evident when you do your descending abdominal aortogram before doing your selected images, but you definitely don't want to forget about the accessories because those are prime targets for denervation. Click next, please. And here's the angiogram of her right kidney. You see that she has a single renal artery on the left. Excuse me, in the right kidney. Go ahead. So sometimes it's hard to remember exactly where you've been because a lot of the renal vessels are tortuous and there can be a lot of branching and complex vascular anatomy. We've devised this system of annotating our screen every time we do a successful 60-second ablation, just to remind us where we've been. There's really no indication to go back over areas that you've already performed a successful ablation, but you also don't want to miss some of the larger segments. And so this is one of the ways that we keep track of that. You may have similar ways of annotating your screen in your systems. In some of the rooms that aren't new, we can also write on the screen with like a sterile marker. Next slide, please. So she underwent renal denervation a little over 2 years ago, and here's her renal anatomy that we just described. Our procedure in her was 87 minutes, and we used about 80 cc's of contrast. She had no complications, and she was discharged the same day. In my experience, almost all these patients can be discharged the same day. I have not encountered a patient that had to stay overnight. And one of the reasons is because complication rates are very low. And so we can discharge them with confidence, similar as we would a same-day outpatient cath. And, as long as everything seems to have gone smoothly during the procedure and the immediate post-procedure period, it's very safe to discharge these patients. And here are her follow-up blood pressures. And you can see, other than a little bit of an outlier at 3 months, she had a really nice steady decrease in her blood pressure in the first 12 months that we followed her. After 12 months, we've sent her back to her primary care physician and cardiologist in Tennessee. So we stopped following her at 12 months. And I think that's pretty much, that's adequate for a patient that, 12-month follow-up that's had a nice response. Please go forward a slide. And just to show you how some of our patients have responded to the radiofrequency denervation. Over on the right, these are actually my own personal patients. I gathered data from the first 25 simplicity spiral radiofrequency denervation cases that we did. And here are their results. We saw a really, really nice steady drop out for the first several months afterwards. And this is similar to reports of much larger patient pools. This one happened to be published in Europe, and this was a 4,000 patient meta-analysis. And you can see, again, you have a nice precipitous drop in the first few months. And, as the data from the larger randomized sham-controlled trials shows, you continue to have a steady drop at least out to 3 years. But we also have data that shows that drop continues. Next slide. So I want to thank everybody, thank TIO for inviting me, and thank the audience for tuning in. I think renal denervation is going to be a special part of my practice and, a career highlight for me. And this is very exciting for treating patients who previously did not have many other options after medical control of their blood pressure was unsuccessful. Thanks for having me.
Well, really great case and great data from your own practice. One question that's come in that I'll just ask to you right away is the questioner states, I'm interested in how anatomy changes ablation strategy. You did mention accessories, of course, but any other tips or tricks beyond just considering the presence of an adequate sized accessory renal?
Yeah, thank you for that question. So the renal anatomy seems to be, at least to me, and I do a lot of vascular work, seems to be some of the most highly variable and sometimes complex anatomy in the body, especially if you have a lot of tortuosity and branching. And Dr. Tirani is going to talk about some of the anatomic factors that go into the record paradise system later. But at least for the Simplicity device, you really want to get into those major branches beyond the first, beyond that first major bifurcation or trifurcation, because we know that the density of sympathetic nerves increases and is closer to the vessel lumen as you get further out. So sometimes if you have complex anatomy, you need to use some of the same tips and tricks for getting there as you would with a complex coronary case. Sometimes we're doing wire exchanges through over-the-wire balloons, just because the wire that we can use to navigate the anatomy, is not a great support wire for advancing the device. So anatomy certainly does factor in that. I actually think that this has made me an even better wire user in complex anatomy because of some of these considerations. But you'll find that with a supportive wire, this catheter really advances nicely as long as you have a little bit of patience to do what's needed to get a complete ablation. So anatomy highly factors into, I think, case time and contrast usage. But ultimately it's worth it to get the type of results that we demonstrated here.
And we'll get into some of the technical aspects in the next couple of presentations as well. But just a question for the panel: what you all are doing at your places in terms of same-day discharge? Is that something that you're doing sometimes, commonly, routinely? Anyone want to opine, or perhaps get a quick opinion from everyone? Yes, please.
Well,
That is routine.
Pretty much routine for us.
Mm-hmm.
Same. Again,
Yeah. So
patients the same day.
Yeah. So
Dr. Tirani, you were I think.
I apologize. Yes, that is a routine practice at our institution. We typically have 2 hours of femoral bed rest, and then otherwise it's a same-day discharge with outpatient follow-up.
And Dr. Kriptene, I think you were also starting to say what you do at Columbia.
Yeah, same day. It's just watching the groin and using closure devices and standard practice.
Great. So that seems to be a consensus and evolving practice. Well, terrific. Again, just to keep us on time, maybe now we will move on to Dr. Kriptene, who's going to talk to us about practical realities of renal denervation, different procedural considerations. How do we define success? Really relevant topics. Dr. Kriptene, the stage is yours.
Well, thanks so much. And pardon me for my voice. I'm just getting over a post-viral thing. So hopefully it will last. I have a cough drop in my mouth. And this will hopefully bookend a little bit with Dr. Randolph's talk as well as the other two talks, because I think when you define success when it comes to renal denervation, there are really technical ways of doing it, but I'm ultimately a clinician. And so when I look at a patient, I sort of always want to figure out what am I trying to accomplish by potentially offering a procedure to them. Essentially, Stephanie showed you this. I'm not going to go through it in detail, but remember, even small drops in blood pressure across a population of patients, for instance, your entire clinic population or your practice's population, will really affect their outcomes. And so to me, this is one way of looking at success. If you're able to reduce the blood pressure profile of your outpatient clinic by just 2 millimeters of mercury, you can drop stroke mortality and ischemic heart disease mortality by 10% and 7% respectively. So when I think of blood pressure and renal denervation as one component of that, I want to think about how can I get better blood pressure control among my patient population? And it's not because I just want to check off the meaningful use box. It's actually because it can affect people's outcomes. We saw data like this showing how badly we do at this, even for those that are taking antihypertensive medicines in the United States. Rates of control are hover around 60, 70%, which is pretty much abysmal. But there are some practical realities to this. And that is that even though we have many medicines that can control blood pressure effectively, many times we start medicines and patients stop blood pressure medicines at a rate of 50%. If we look at the hard facts, if I prescribe an antihypertensive, the likelihood a patient is going to fulfill that prescription is about 2 in 3. And the likelihood that the patient is going to take a medicine that they fill as directed is about 2 in 3 also. If you multiply those two independent probabilities together, you're right at 50% or just under it. And so this is a hard fact of life. And when I think about success, I want not just success in the short term, but long term. And the SPRINT extended follow-up data showed that really, really clearly, in the sense that even in that trial where there was a mortality benefit to treating blood pressure more aggressively, what we saw is that at 10 years, patients drifted right back to where they were when they started. So when I think about success, I think about, can I have the patient take their hypertension seriously and effect measures so as to reduce not only the blood pressure, but their subsequent risk over the follow-up period? Because when we look at the hard facts on this, we just do really poorly. And this is just a failure of multi-drug approaches to treat hypertension. So when we think about renal denervation, I think there are many people who think of this as kind of simplistically. We hate taking medicines. We as individuals don't like taking medicines. Our patients certainly don't like taking them. And so can we just offer an alternative to polypharmacy by doing renal denervation? And there's some sobering facts out there. And the first is that if you look at the very first case report in the New England Journal, looking at renal denervation, proof of concept in 2009, what one sees is that, yes, there is a reduction in blood pressure in a patient with 7 medicines at baseline, going from 160 over 107 to 141 over 90. But the blood pressure is still elevated, 141 over 90 at that time point. And so when I think about success, it's not going to be a cure for hypertension. It's not going to be getting people off their medicines entirely. It's going to be identifying realistic goals for the patient and saying, hey, we want to reduce your risk. We maybe want to help you come off some medications. Those things together will help you over time. And so that's really important to level set. Now, what about the procedure itself? We heard some of the technicalities. I'll go through it in a little bit more detail, in the sense that initially when we were doing renal denervation in the Simplicity Hypertension 3 study, which Deepak led, we thought that we needed to sort of focus around the ostium because that's where the ganglia were. Well, it turns out that's true. The ganglia are there, but the nerves are much further away at that point in time. So if you have devices that have ablation depths that are less than 5 or so, you really do have to go distally. If you're going to go more proximally, you need a device that can get a deeper depth of penetration. And so when you think about procedural success, it is going to be device specific based upon the mechanism of action and the specific device that's being used. The reason this is important is because the only way to effectuate a drop in norepinephrine signaling, i.e. a reduction in sympathetic outflow that then translates to a reduction in blood pressure, is to ablate a certain number of nerves. And this is a nice preclinical study in Jack showing that if you don't ablate up to 50, 60% of nerves, you retain elevated levels of sympathetic activation. And remember, the body also has compensatory mechanisms to deal with this. So we really need to be able to get enough nerves in an effective way, and that's how you define some procedural success. The problem is this is somewhat blind right now because we don't have metrics in the procedure to sort this out, and that's why it's important to get a good ablation. So you saw a little bit about this before. If you're going to do this procedure with an RF catheter, you really need to identify a priori where you want to be ablating. And you don't want to ablate the parenchyma. So all of these things are going to be designed to get those nerves distally as best as you can, but not hitting the parenchyma. And so that's kind of how you think about it. And when you come up with a procedural map and then do that procedure in the lab, you have to sort of plan this in advance. Similarly speaking, with ultrasound-based ablation, you may be getting more of a circumferential ablation, but that's potentially at risk, which is why you have a cooling balloon to protect the lumen. Now, the idea here is that if you go deeper and you can be more proximal, you can get nerves in an effective way. But the challenge is that because this is a deeper ablation, you also have to be cognizant of not going distally enough where you're going to be potentially hitting the parenchyma. So when you're going to do this with an ultrasound-based strategy, and we'll see a talk on this next, you basically want to also plan, whether it's the main arteries or accessories or both, where exactly you're going so that you can safely ablate the nerves without targeting the parenchyma. Now, when we think about other metrics of success and how we can expand these populations, Tiffany spoke about this, so I'm not going to go through it in too much detail, but recognize that the treatment indications by the FDA are really broad, indicated to reduce blood pressure as an adjunct to hypertensive therapy and lifestyle modification when those things don't adequately control blood pressure. And if you sort of expand this, you can come up with a massive amount of patients who might be eligible for renal denervation. But that's not, I think, the right way to manage this condition, because there are effective things out there like lifestyle modification, medications, et cetera. And maybe we ought to be focusing on a narrower population of patients. It's also important when we think about success, not just to think about the procedure, but how can we be better with medications? As a resident, when I was in my training, combination antihypertensives just came out, and I thought they were a marketing gimmick. I thought they were just a way to sell generic medicines in a way that the companies could charge more for it. Well, I was wrong. Good news is they're all generic now. Many of them are. But the other good news is that in the guidelines, it's pretty clear that if you start patients with stage 2 and above hypertension on multiple medications at the same time in a single pill, you can get a better effect. We showed this in clinical trials, and that's what the guidelines say now, is you really want to go with single pill combinations at once daily dosing so that you can be successful in what you do. We heard a little bit about primary hyperaldo. I'm not going to talk much about it other than to say it's almost 20 to 25% of patients. You need to screen for it. You withdraw the MRAs if you have to, but otherwise you can just test and go from there. It's a very easy test to sort out. Where does denervation fit in the guidelines? Well, there's some prescriptive guidelines like the European guidelines that show you that you really have to take 3 medicines and then add a 4th, 5th, and potentially a 6th agent before considering it. In the US guidelines, actually, this is from the slide set, it's perhaps a little bit more upstream of that as an adjunct to patients who actually fail legitimate efforts at lifestyle modification and medications as a whole. But when we do this, the reason why it's more downstream, and some of the questions in the chat were about this, is because we know that not everybody's going to respond. And this is a procedure that patients have to go through. It's not cheap. And remember, about 2 in 3 patients have a response as characterized by drops in blood pressure. Now, this is a static single time you're measuring blood pressure in the trials. There may be patients that don't respond early, but respond later and get maybe better blood pressure control. I took care of a patient who was actually quite disappointed because felt that the blood pressure wasn't controlled. We put an ABPM on them, and actually the patient was controlled. It was just that every time they came to the office, it was a white coat effect that was going on. Remember also that medicines varying in the background can also change things. In the trial that Deepak led, Simplicity Hypertension 3, medicines change 40% of the time. So if medicines are changing, it's hard to discern a treatment effect if that's on the background of these medicines that are changing. We heard a little bit about out-of-office measurements, ABPM, and home blood pressure monitoring, super important, endorsed by the guidelines as well. Ultimately, I think the way I think about this and when I think about success, the best paradigm is to fail other things first, do a good workup, and then ask patients what they want to do. Do they want to initiate a new medicine? We have new drugs out that are just approved like Baxdrostat, or do they want to consider a procedure to help them? My dog is going crazy. I apologize. Someone just randomly wrote something rang the doorbell. But what I do now is essentially I look at patients and I emphasize first line lifestyle modification and medications. The reason I do that is because I know that only 2 in 3 are going to respond to a procedure. And so if I don't do these other things first, then that's going to be problematic for them because they'll be disappointed. The second part is that I do my workup of secondary hypertension in a really good way, in a way that I've learned from our hypertension specialists. And I start thinking about denervation, but I don't think about it seriously unless I have another follow-up visit where I've really made sure that all these other things have failed. I also engage our hospital and our administration to help us get approvals for these cases. And I think by doing so, you can be a good clinician and offer a valuable therapy like denervation at the right time point in the patient's disease journey. Thanks so much for listening to me. I'm sorry about the dog, but happy to take any questions at this time.
Oh, I was happy to hear from your dog, as a matter of fact. I think it added to the session. It's what made Zoom sessions fun initially, getting to know people's pets. Well, a lot of questions have come in, and maybe I will just ask a couple of technical ones, just since you addressed some of those. What type of sedation do you use during these sorts of procedures? Someone's actually asking, is general anesthesia needed? And that wouldn't really typically be called for, but what sort of sedation is the question?
You know what I like to call it is it's colonoscopy style sedation, not cath style sedation. So you know, it's funny. Outside the U.S., you know, we have an interventionist who's going to come to us from Norway, and they don't use any sedation at all, even for like long procedures. Well, in the New York area, you can't do that. So we give sedation, but because the denervation is certainly felt, it's the type of thing where you need to have people more sedated, and you always want to get in front of that ahead of time. But we don't typically use don't use general anesthesia, and most of the trials have shown that you don't need to use general anesthesia, and you still maintain your blinding.
Yeah, no, it's a great point. The trials have shown that, but you're right. Some European colleagues, it does amaze me how they get away doing CATs. I'm not talking about renal artery denervation without using sedation. It's amazing, but I think you're right. In New York City, it wouldn't work so well. And maybe I'll just open this up to the whole panel. This question from the audience: what does technically good radiofrequency denervation patterns look like? Anyone want to opine on that?
Yeah, there are discussions regarding real time testing to see if we've gotten an adequate denervation, but because we're not going over the same segment more than once, I think an adequate denervation at the time of the procedure is really everybody's agreement in the room that you've hit all the major segments and you've done as much as you can. Certainly, that's more important with the radiofrequency catheter, where you're getting into those more distal segments. But there are certainly recommendations for how many balloon inflations and cycles that you want to do with the record device as well. I think ultimately, right now, we're just looking at response.
Yeah, no, that's
as
a
far as I
terrific
know,
answer.
no testing on the table. Yeah.
Yeah, no, that's a real
Sorry.
challenge, actually, that no one's successfully developed yet. That is real-time feedback to know, was it really effective denervation? Well, you mentioned ultrasound, and on that topic, let's turn now to Dr. Tarani, who will demonstrate an ultrasound-based renal artery denervation in I think in a recorded case, but maybe it'll be live. We'll see. So, Dr. Tarani, over to you.
Well, thank you again, Dr. Bott and team, for having me here today. So I'll be discussing a case on a patient that was treated with ultrasound-guided renal denervation. So this is a 50-year-old man that we had seen in our hypertension clinic that had all the classic risk factors: coronary disease, an underlying cardiomyopathy, dilated ascending aorta, 2 prior strokes, and he had significant CKD, as you'll see here. His GFR was 28. Also morbidly obese, diabetic, and obstructive sleep apnea. And as you'll see here, he had very significant isolated systolic hypertension with a bit of a widened pulse pressure, but did not have valve disease or any other conditions that could contribute to that. And he was referred for evaluation. So in our program here, we work with Dr. Bach and the Virginia Heart team, but as part of the ANOVA hypertension program here, as you can see, these patients are oftentimes referred to us to undergo screening confirmation that this is indeed resistant hypertension. And they undergo that, through a number of different ways. We're able to contact their pharmacy, pill counting, a number of other mechanisms that our allied health professionals help with that. Once we've determined that that indeed is the case, they'll oftentimes get a 24-hour ambulatory monitor. As our colleagues have discussed, up to 1 in 5 and 1 in 4 cases can have hyperaldosteronism. So they undergo a secondary workup, and that is ruled out. And then ultimately, in shared decision-making manner, we then participate in these patients undergoing evaluation. So this is the hypertension workup that this patient underwent. As you can see, the secondary hypertension workup was unremarkable, did not have any significant renal arterial stenosis, and the kidneys were not atrophic, and they were appropriate size. So we'll be discussing here the Paradise ultrasound renal denervation system. As many of you know, the anatomy and the location of these nerves plays a critically important role. So as these nerves are emanated down the thoracic down the thoracolumbar chain, and then they line the vessels. They're very densely populated, more proximally at the ostium. They're lesser in number, larger, and then further out from the lumen. But as we progress towards the mid and distal shaft and into the distal segments, they become smaller. They become more rich and dense, and these plexi are very densely innervated along the lumen of the actual artery. As we discussed, this technology is very elegant, and we offer both technologies at our health system, both the ultrasound and the radio frequency. With this technology, the ablation modality is ultrasound based. It's full circumferential denervation, in which the energy is emitted in a full circumferential manner with up to 6 millimeters of penetration depth to maximize coverage of these renal nerves. And as our colleagues discussed, we also have a hydrocooling system here to minimize any thermal injury to the lining of the vessel wall. This system, as we discussed, for us as interventional cardiologists, it's very intuitive. It's a balloon on a wire catheter-based method that helps to reduce blood pressure through essentially, endovascular inflation and the release of ultrasound-guided energy, but without in any way causing either damage to the wall of the vessel, endothelial integrity, or renal artery ischemia. So as we discussed, it provides this full circumferential energy to provide thermal ablation, and as was discussed earlier, it's meant to short circuit the sympathetic nervous system activity with these nerves that are oftentimes in a adrenergic overdrive, and they're being activated, which results in the release of hormones that then mediate resistant hypertension. The energy, as we discussed, it is released in the form of ultrasound waves, about 6 millimeters of penetration depth. It's 7 seconds of sonication energy, and it really penetrates through through the water with minimal energy loss. And as a result of that, it helps to minimize impact by the heat sinks on the veins, the lymphatics, and the other important tissue systems that are adjacent to the actual nerves in the wall of the vessel. So as we've discussed before, again, circumferential energy, it's through a transducer that really maximizes treatment zone. It is a cylindrical transducer that then, through the use of automated algorithms, adjust the ultrasound energy level based on catheter selection. And as we'll discuss, there are different balloon sizes that we use based on an algorithm. And really the goal is to provide, great penetration without any significant tissue contact or injury. As was discussed earlier, there is a cooling fluid circulation inside the balloon that keeps the inner vessel wall temperature low so that there is no significant thermal injury as a result of the luminal contact with the balloon that happens during the treatment. Go back to my previous slide. And as you'll see here, all these patients undergo selective cannulation of the renal artery, similar to the Simplicity system. And then with this, very elegant chart that you'll see on the right side here, based on the size of the artery that we almost exclusively quantify using ultrasound, despite the fact that they've already had either a duplex or a CTA, we're then able to tailor the balloon size to the size of the artery. So our sedation, that we do this, and we do this for both URDN and the radio frequency system, is after they've been sedated many times in the pre-procedural bay, we'll give them Benadryl, a dose of Solumedrol for its anti-inflammatory effect. And if kidney function permits, we'll oftentimes give them some IV Toradol. This patient, that was not the case given underlying renal impairment. Oftentimes, we'll start with a good bolus of Versed and fentanyl. And as we'll talk about here, then we go through standard procedures for aortography, which is oftentimes with a 5 French omniflush catheter or pigtail. Oftentimes, we place it between L1 and L2, and that's standard technology. And with minimal contrast, in our practice, typically DSA and a slight shallow LAO approach, we then take a selective angiogram. So as you'll see here with this case, this patient had a distal abdominal aorta that had minimal plaque. Each kidney had one main renal artery, with the right side having a slightly higher takeoff. And oftentimes the LAO approach helps us to differentiate and make sure there's no other accessory arteries, and it helps us to make sure that we're really locating the right vessel here. And then cannulation can be done in a number of different ways. We oftentimes use a 7 French IMA or an RDC guide. You can also use the multi-purpose guides. We can also oftentimes use the torque sheath guide combination that's provided. And again, it's important to position the tip 3 to 4 millimeters to facilitate, good coaxial engagement and to be able to help facilitate delivery of the Paradise catheter and the balloon. In some cases, in which there's a difficult engagement, oftentimes we'll use an 035 glide wire and either a 4 or 5 French diagnostic catheter that can serve as a telescope to help rail the guide and then ultimately the balloon and the catheter. And then really with the selective engagements, minimal contrast, 2 to 4 cc's. In some of these patients, if we're concerned about the presence of spasm, we'll oftentimes give them some selective vasodilators. In our practice, that's typically IA nitroglycerin. And as you can see, there was just minimal eccentric plaque in the proximal portion of the left main renal artery. And we use intravascular ultrasound for all of our cases. And as we did it in this case as well, to ensure that there was not more than 30% renal artery stenosis. We perform intravascular ultrasound for all of our cases, even if they've had a duplex or a CTA. And that then helps us to be able to ensure, A, that the vessel is the appropriate size for the balloon, so typically between 3 and 8 millimeters, and also to make sure that there's no anatomic complications or any anatomic contraindications to being able to deliver the therapy. So this was the intravascular ultrasound, and as we showed, the size of the vessel was appropriate. And with these cases, oftentimes we will use a non-hydrophilic 014 wire with a bit of a body, so either mailman wire, balanced heavyweight wire, even sometimes a stabilizer wire. And then we begin treatment 5 millimeters proximal to the main branch. So as Dr. Baca described with the radiofrequency catheter, the goal is to provide a complete denervation to all the branches. But with this technology, we're able to provide treatment just to the actual main shaft and sometimes extending into the proximal branch. And usually if the vessel is at least 1.5 millimeter or more, they can get 3 treatments in that branch. When the balloon is then finally inflated with minimal contrast, we give a little bit of contrast to ensure that the balloon is actually fully opposed to the vessel. And that is, another sign of assurance that we're using the appropriate size balloon. So we're able to provide complete denervation. Once we've completed that, then we'll take a final picture with some minimal contrast to ensure that there's been no evidence of any iatrogenic injury here. And that was indeed confirmed. Similar techniques are used for the contralateral side. Again, intravascular ultrasound is very important, and we want to ensure that the vessel is between 3 and 8 millimeters and that there's no anatomic contraindications. And similar concept again, just a very low amount of contrast injection after the balloon is inflated to assure that we're in the right location. So we're at least 5 millimeters from the pelvis, at least 5 millimeters from the ostium, and that the balloon is fully inflated and opposed. And again, a final contrast injection to make sure that there's no iatrogenic injury. In this situation, the patient had minimal contrast, 1 perclose suture, which is standard of practice. And then this patient was then discharged home 3 hours later. So this patient, along with many of our patients, they'll typically have a 7 to 10 day follow-up, typically with one of our APPs, just to do an access site check to make sure that there's been no issues. Then we'll see them at 3 months, 6 months, and then ultimately at 12 months. This patient, remarkably, just at 60 days, as you'll see here, had a significant reduction in their systolic blood pressure and was able to be weaned off of 2 of his meds. It did not have any significant renal impairment after the procedure. These are interesting patients. Yeah, I think the patients with isolated systolic hypertension, especially if they have underlying comorbidities or if they're older, are the ones that we're seeing more and more in our practice. And obviously, with a lot of what's coming out with the CMS guidance, we obviously want to make sure that we're being very mindful of patient selection. But this patient in particular, we would consider him as a super responder. But as we know, there is a broad spectrum of variation among patients and how they respond to their therapy. So on behalf of the Inova Shar Heart and Vascular Institute, we want to thank you for the opportunity to present on this forum. Thank you.
Yeah, really great presentation. Looks like we've got a little over 5 minutes for the remaining questions. Let me try to get through them. Maybe I'll just start off with a question. Any difference between these two systems, radio frequency-based or ultrasound, in the opinion of any of the panelists, of those of you that have used both or have familiarity referring to both?
I think it's important to have both of these in, in your health system. As you know, patients many times are very informed when they come and they ask questions. We don't have a lot of randomized data. As you know, there was the radio sound study that looked at ultrasound versus radio frequency based on whether there was branch vessel treatment or not. But as we get more data, we will learn more. But both of them are quite effective, very safe, very elegant technologies, and we're able to utilize minimal contrast while at the same time minimizing any significant patient discomfort with both.
Great. Any other thoughts on that point? Well, then what about reimbursement? That's another question that comes up in the United States. Oh, Dr. Kirtany, were you going to say something about the comparison there?
No, to the reimbursement question, I'm assuming you're asking, what's the current status about it? And
yes, in the United States, of course.
Yeah, I mean, look, I think the challenge is that there's an NCD, and that means that for Medicare patients, there is a pass-through payment that should cover the cost of the device for most labs. It varies based upon geography. But the challenge is that if you look at the randomized trials, the average age of the patients was 55. And so Medicare is maybe not the best population. There does not appear to be a decrement in effect as patients get older. But we all know that if you have an 85-year-old patient with stiff arteries and they're volume sensitive and that kind of thing, that's probably not going to be something that's sympathetically mediated. So we need more data in that population. For the private payers, though, it's catch as catch can. There are some geographies where they're starting to approve it for the right patients, and there are others where it really becomes a challenge. And so I think it's a slow rollout. There's some pretty rosy speculation that was made by some of the companies initially. I think most have tempered that down a little bit as these things happen. But I think with enough perseverance, you can pick the right patients. And the good news is that the patients that are most elevated blood pressures, they tend to respond even better. I didn't speak of that in my talk, but that's kind of true. And so in some respects, the brakes on fully using this are actually useful in the sense that they may actually make sure that we're using it in the patients that really need it.
Yeah, great points. Here's another terrific question. Where does renal artery denervation or ultrasound denervation or any of these approaches fit in versus new drugs, things like aldosterone synthase inhibitors, where there'll likely be a few of them available relatively soon? Any thoughts about that? Because on the one hand, the device-based approaches will be expensive, the new drugs will be expensive, so maybe cost won't be such a differentiator there, but just in terms of patient benefit efficacy, any thoughts?
I mean, I think that this is where you really get into. Go ahead, Jeremy.
When I see a patient in the office in our hypertension clinic for the first time, and we're talking about medical versus lifestyle versus procedural intervention, I tell them that the goal of the program is to fix their blood pressure. And it doesn't matter to me how we do it. A lot of this comes down to what's going to be effective and, what the patient's preference is. And so, new drugs that have potential, that's wonderful. I think, again, we really try and focus on the right plan and considerations for that specific patient. And, it's the biology and the social issues and they're so patient specific that having more tools in our toolbox to potentially address the hypertension is wonderful. So I think the new drugs are just as exciting as the new procedures. But ultimately we're going to be tailoring that to our, the specific case that's in front of us.
Yeah, no, that's a great answer. And, furthermore, the guidelines, it's for like the cholesterol guidelines, the blood pressure guidelines as well. Normal keeps dropping every few years based on data. So, assuming you can get patients lower, these days even lower than 120, for example, with a patient with coronary artery disease. If you can do it without side effects, that's often the recommendation. So very likely that combination therapy in some patients, that is current generic drugs, combo drugs, as Dr. Kriptene mentioned, the guidelines recommend that, but that's still a practice that seems to be underutilized. But then beyond just generic drugs, newer drugs, and then these procedural-based approaches, seems like they could all have complementary roles as we get more aggressive about intense blood pressure management. We've got only a couple of minutes left here. This is a question about the most effective role of nurses in the multidisciplinary management of these sorts of patients. Dr. Randolph, you mentioned the team approach and you mentioned nurses and pharmacists and so forth. Any specific guidance that you can give there?
Yeah, I mean, I think especially advanced practice nurses or nurse practitioners and our physician assistants and our clinical pharmacists. I mean, I don't know what your clinics are like, but it can be challenging for me to be able to personally get these patients back as frequently as they really should, guideline based, be following up with, for their hypertension, for them to actually see me. And so I think having those other options for patients to come back and have blood pressure checks with nurses, or I sometimes find it more beneficial for them to be able to see the nurse practitioner, PA, PharmD, clinical pharmacist, and be able to make medication adjustments at those visits as they come back, can be very, very helpful to be able to better medically manage these patients. I think that the specifically in the RDN process, as I mentioned before, just tracking the authorizations, prior authorizations, where these patients are, keeping in touch with them before the procedures, touching base with them after the procedures. I think those are all roles that nurses are very, very well adept at helping in a hypertension clinic.
Great. Well, I'm getting the 1 minute warning. I just want to say to all of you, fantastic presentations. I'm sure the audience will agree in a really rich discussion. Renal denervation is clearly a space with real momentum, and I hope this session has helped clarify both the evidence and the practical path forward to the audience. Now it's time to move on to the next session. Thank you so much for the great questions.